Good morning, ladies and gentlemen. Thank you, Lalit. Uh, After diabetes, in terms of numbers in this country, I think age-related macular degeneration is the next important disease. This is my disclaimer and my financial disclosure. Now, exudative ARMD is not a single disease. You have CNVs due to predominantly classic lesions, minimally classic lesions, occult lesions, various types of occult lesions, and these different patients behave differently, though that's not stressed upon adequately. The Marina and Anchor study showed us very clearly that sustained visual acuity gains were possible with monthly ranibizumab, and those could be maintained for a long time, and the gold standard for that was a monthly regime till recently. But the unfortunate thing is that that's an extremely intensive and exhausting regime, both for the patient and the doctor. The sustained study also showed us that while you need monthly treatment for many, but there is a need to individualize treatment, and there are almost 20% of patients who only need around the loading dose of 3 injections, don't need any more. And at the same time, there's the other end of the spectrum who need injections virtually monthly. Today, we have a lot of choices. We have ranibizumab in different forms, we have bevacizumab, we have aflibercept, we have brolucizumab, and we have faricimab. So how do we manage today? Well, not only do we have different drugs, we also have different regimes for treatment. Starting with the monthly one, we now have 2 monthly, quarterly, PRN, and treat and extend regimes, which have all found utility. How to decide for an individual patient? What is the optimal treatment? That depends on efficacy, safety, ease of use for the patient and doctor, and the intervals that you can maintain between the treatments. The Sailor study showed us very clearly that if your monitoring is every 3 months, that is grossly inadequate. The gains in the first 3 months are lost by the end of the year. And a simple change, monitoring monthly, treating 3 monthly, even that changed the results and gave more sustained visual gains in the sustained study. So what we learned from these studies was that if you're monitoring, it should be monthly. There are very stringent guidelines for retreatment, including minimal change in BCVA, any evidence of fluid, increase in the central retinal thickness, any new hemorrhage. So their fundus examination is also extremely important. Now, the latest regime to be used, which is found to be most safe, is the treat and extend regime, where you slowly extend the duration between treatments, and you decrease that duration if you find any recurrences. The Altair study made it even a little more strict. It shortened the interval only for any persistent fluid as well as increasing fluid. It only maintained the interval between injections if the fluid was decreasing, and extended the interval only when there was a dry lesion. So I believe that possibly the best option for patients who are one-eyed or those who become stable but are not drying completely is a treat and extend regime. On the other hand, most of the two-eyed patients who have complete drying of the lesion are probably the best treated by a PRN regime with what we call a monitor and extend. That means you monitor, they stay dry for 6 months, and you can then extend the intervals between the follow-ups. Which drug is optimal? Well, for me, even today, for type C NVMs, I find ranibizumab is extremely effective, and that's my first-line drug. For type 1 CNVMs, I believe aflibercept is better than ranibizumab, and that is my drug of choice. Now, if you don't have access to anything else, remember monthly bevacizumab also is almost as good as monthly ranibizumab, though the macula dries less quickly and less often. Brolucizumab is probably more effective in drying the fluid, any types of fluid, but with faricimab, you can maintain even longer intervals than 12 weeks in the majority of your patients. As far as safety is concerned, both ranibizumab and aflibercept are safe. With bevacizumab, we've had episodes of cluster endophthalmitis. Not the drug per se is safe. Brolucizumab does carry an additional risk of intraocular inflammation and a small risk of inflammatory vascular occlusions. In case of a systemic problem, recent MI, recent stroke, the only safe drug for you, which is validated, is ranibizumab 0.3 milligrams. How much can we increase the interval between these treatments? Well, the fluid study showed us 7 weeks for ranibizumab, brolucizumab up to 12 weeks in more than 50%. The Altair study showed us that aflibercept, you could go to an extension of 12 weekly within 60% of patients and up to 16 weeks in 40% of them. And finally, with faricimab, greater than 12 weekly extensions are possible in over 80% of patients. Today, the workhorse of management in AMD is actually aflibercept. How do I actually manage my patient? So you give the 3 loading doses, and loading doses are necessary in AMD. At the end of 3 injections, 1 month later, if the lesion is dry, as I said, if it's a one-eyed patient, I would put into a treat and extend regime. If it's dry, I will monitor for the next 3 months, every month. If recurrence occurs, I treat it if it does, on a PRN basis. If it doesn't occur, I increase the monitoring intervals from 4 weeks to 6 weeks to 8 weeks, and finally up to 12 weeks if the patient stays dry. In patients who need ranibizumab more than 8 weekly, say 6 weekly, 4 weekly, those patients should be considered for PRN aflibercept. Now, a large proportion of patients don't dry at the end of 3 months. They still have some fluid. So these patients you give for the next 3 months, every month injections. If they dry, now the algorithm for them becomes what I told you before in case the patient becomes dry. In case it doesn't become dry, you will find that finally the amount of fluid becomes stable. If the cysts are there, they remain the same. If subretinal fluid is there, that remains the same. And these patients now you can put into a treat and extend regime, increasing the duration between the injections till you reach at least 12 weeks with ranibizumab or up to 16 weeks with aflibercept. In patients with occult lesions who have stable but not dry lesions after the loading dose of aflibercept, I will try a treat and extend regime, and if I can go beyond 8 weeks, I will continue that. If I can't do that, I will switch to either brolucizumab or faricimab. When do I switch? To switch, if you have a patient who's on ranibizumab and he's getting a recurrence every 7 weeks or less, or is stable and I can't extend him beyond 7 weeks, I will consider a switch to aflibercept. A patient who's on aflibercept and I can't increase the durations beyond 7 weeks, I will consider a switch to brolucizumab or faricimab. And if the patient has received a brolucizumab, now he's not completely dry at 4 weeks. I don't want to give the next injection 4 weekly. I try to delay at least to 8 weeks. So in between, I will give 1 injection of aflibercept. This is just to show a patient who was on Eylea. The patient had received the injections every month for almost 16 months, was still not drying off. And then we gave him a brolucizumab. There was no change a day later. 1 week later, there was some decrease in the lesion. By 4 weeks, there was still some cyst left. I gave him an aflibercept. He did not dry further, and then brolucizumab was repeated, and there was almost complete drying of this lesion. So this patient, after that, has been on 3 monthly brolucizumab. But the important message here, it's not brolucizumab or ranibizumab or aflibercept. A long-term outcome done in with a treatment and extend regime with all these 3 drugs revealed, no difference in visual acuity outcomes or number of injections over a long term. And what did it show? The number of injections was not same. The fluid was also the same. And most importantly, what worked? Eyes that got more injections did better. Eyes that had treatment for a longer period did better. So ultimately, what is more important is the number of injections, the more the time till injections are continued. And that gives the best outcomes. In fact, there's another study called the FIDO study, which gave fixed interval dosing of 4 to 8 weekly. And for 7 years, at 7 years, they maintained better than 612 vision in more than 40% of patients, and more than 618 vision in 2/3 of the patient. So even the most important thing, the message, don't stop the drug. What is more important is giving the treatment, not particularly running after one drug or the other. Ladies and gentlemen, the basic principles, there are 2 principles. One group tolerates no fluid, the other tolerates some. We do not tolerate fluid. We do not like to tolerate intraretinal fluid. We don't like to tolerate subretinal fluid unless it's completely unresponsive to treatment. For sub-RPE fluid, don't run after it. It doesn't go with ranibizumab, partially goes with aflibercept, and even with the other drugs, it may not go fully. But you're not treating sub-RPE fluid. You are treating only the intraretinal and subretinal fluid as a routine, and that's it. Ladies and gentlemen, what we've learned over this period is that aggressive monitoring is the key. And this monitoring is needed up to lifelong in a patient, even after he becomes dry. Greater the number of injections, more intensive and longer the follow-up, better the visual outcomes. Initial PRN treatment gives you the guide to change the patient to a treat and extend regime later on. But the most important thing is have a high index of suspicion for retreatment, and eternal vigil is the price you pay for vision in patients with CNV. Thank you very much, ladies and gentlemen.
Thank you, Dinesh, for this crystal clear messages. Couple of them I may like to repeat, even at the cost of repetition, is in contrast to diabetes, where the message here was don't stop in ARMD, because ARMD is different disease than diabetes. Second was this, because fluid theory convey different messages, that SRF is tolerable, and some people also said that SRF fluid may have better vision also. But this is not acceptable because there are now better drying agents available. The other thing which, Dinesh, I wanted a small comment was that in your case, which you showed aflibercept, not responsive, then switch to brolucizumab, then again come back to aflibercept, if not then brolucizumab. Why this lassi?
Okay, so the basic, you know that with brolucizumab it's been repeated that you should not be giving the injection every 4 weeks. You should try to increase the duration. Now when I have a situation when the patient not responded fully, I don't want to leave the patient with no treatment. So the aflibercept is a stopgap arrangement in this situation. And that just carries on for another month, then you repeat the brolucizumab. And in this patient, after we gave the brolucizumab, became dry for the next time, and then stayed dry for 3 months before a recurrence occurred.
But ultimately, again, you brought to brolucizumab
yes.
for 3 months.
So it's only that if in less than 3 months I need to repeat a drug, I will give aflibercept rather than giving brolucizumab.
Today, with the availability of faricimab, would you consider brolucizumab vis-a-vis
So if the patient now, there are patients who
because
can't
the
go
reason,
for,
the reason I'm asking is because this newer generation of agents, which promise extended duration, and with the, faricimab saying 3 Ds, duration, durability, and dual mechanism of action, will you consider brolucizumab in a patient who is not responsive to aflibercept or faricimab?
Yes, today you're right, Lalit. I would actually prefer to give faricimab, but these are early days for me with faricimab. I've only given a few injections. I have had early responses also, but I don't have a 2-month follow-up to see how long the it stays. But yes, I would like to, instead of brolucizumab, give faricimab if the patient can afford it.
So one last question before we ask Ashish to come is that if you believe that faricimab in your initial experience also is working in resistant patients, so why not throw away aflibercept and start on faricimab?
Yeah. You see, whenever anything new comes, you want to first test it out. And the best way to test it out is in the worst patients. The reason is that if something works in the worst patients, then I'm sure it'll work in the good patients also.
This is acceptable. This is acceptable. You see,
obviously. No, I'm saying this is why maybe tomorrow, maybe after 6 months, if you ask me, I will shift to faricimab. But as of today, that's not my drug of choice.
Okay. We presume that based on the data of Tanya, Lucerne, whatever is available, because though there has been PRCT done and you have to pay weightage to that data also.
Yes.
That data is not, has been approved by FDA. So I am happy to say that you will consider giving faricimab as first-line agent also.
Yes, but remember, it's then it will become an economic decision because...
No, I'm coming to economic. Yeah. Last question, economic also, because economy, I will cover economic. If you consider the yearly treatment, because duration, if faricimab after the loading dose, if it is maintained on even 10 or 12 weeks, yearly cost becomes less.
Exactly. So basically, I expect that 70 to 80% of patients on faricimab, we will be able to shift to 12 weekly injection. If the cost of a 12 weekly injection, if it turns out that this fact is true, and the cost of the 12 full years injection is cheaper with faricimab, I will ask the patient to shift.
Okay, thanks, Dinesh, for some clarification. But remember, one point, I still would, make here, that out of all the second generation and first generation anti-VEGFs, there's nothing to compare brolucimab drying capacity. Drying
It's
ability,
early days. I don't know yet.
No, whatever data I have of brolucimab, I think.
One company.
Yeah. So brolucimab ki drying na wo unmatchable hai. Is not. I'm not saying that all patients statistically, but capacity of brolucimab maybe because of smaller molecule and high molar mass. Capacity is actually.
Okay, so my experience with brolucizumab.
There is a fear of IUI. There's no doubt.
No, I guess one thing I want to say. My experience with brolucizumab is only in intractable cases. Those who have not responded to multiple doses
But
of
believe me,
aflibercept. And let me just tell you, the figure is not the same as general treatment. The figure is 1/3 complete resolution for 3 months. 1/3 partial resolution requires injections more than 3 months. And 1/3 no response.
Dinesh, the question is there is a huge amount of data of brolucimab available, huge thousands of patient data available in the country, in this country. Your data may be, say, a few patients.
That's
believe me,
treatment naive.
But believe me, there are patients available. There's no question about it that the drying of brolucimab is much, much superior.
One patient of
comment.
mine with brolucimab, I'm giving every 5 weekly. And I have given somewhere around 22 injections in that patient.
More than 30 injections have
Yeah.
been given.
And that patient didn't show any response. What you commented, ki you should not give before 6 weeks. But I'm regularly giving, and it's patient comes and tell me my vision has gone down.
Every 6 weeks.
Yeah.
This is exactly the point I'm trying to make.
5 weekly injection
That
to them.
despite the data which is shown over there, it's not every 12 weeks. Many patients are every 6 weeks. Even the drying is not total in every patient; it's partial in many patients.
Yeah. But the point to make here was not the efficacy, but the fear of IUI. Maybe it's different than what data we have in India, vis-a-vis what data we have from US, because this patient I know because I am also following up this patient, same patient. In a single-eyed patient, left eye, this gentleman, 84-year-old.
Yeah.
84-year-old gentleman has received nearly 30 injections of brolucimab. Not even a single IUI event has noted. Okay, having said that, any other comments from the audience regarding presentation by Dinesh? You can, yeah.
What will be your comments about Ziv aflibercept vis-a-vis aflibercept?
Okay, this is a legal issue and it is completely contraindicated. Now, you must understand why. Ziv aflibercept is not the same thing as bevacizumab. Bevacizumab, there is no ocular alternative available, and therefore you can say off-label use. But here you have the ocular drug available. When you have the ocular drug available, and the company says this is for the eye and this is for the rest of the body, now when you use it for the eye, you're putting yourself at risk. And that is totally your risk. It's nothing to do with the patient, nothing to do with the...
We are not talking about the efficacy-wise, but legal issue can be there.
But same was the issue with Avastin and Lucentis.
No, it's not.
Avastin is not available for eye.
No, that's what. Avastin is still being used
What he's saying is,
off-label.
please understand, what he's saying is, aflibercept is available for the eye.
Yes.
This Avastin is not available for the eye.
The molecule has been changed.
Equivalent for bevacizumab,
Okay.
right?
Chal, in any case, we